The following presentation will introduce you to using the Queensland Adult Deterioration Detection System, known as QADS, in the digital hospital setting. The Princess Alexandra Hospital will be transitioning to this new digital early warning tool in February 2022. The Queensland Adult Deterioration Detection System, or QADS, is designed to trigger alerts for cumulative physiological deterioration in adult patients and adolescents over 16 years of age. The system is widely used across Queensland Health, both in paper-based and digital versions. It is a combination system with medical emergency team alert thresholds for both an aggregate score across multiple vital signs and for severe vital sign derangement on a single parameter, like between the flags. This provides a safety net for incomplete vital sign sets and severe derangement of any single vital sign. The QADS multi-trigger digital early warning tool will replace our current single-trigger digital early warning tool in February 2022. Some benefits of QADS are that it enables more accurate identification of patients at risk of deterioration, and it allows for early escalation to senior medical officers using a graded approach. Standardization of deterioration detection systems across the state will also reduce patient safety risks and training requirements, as clinicians often work at multiple Queensland Health facilities. With the introduction of QADS, there are some notable differences for recognising and responding to clinical deterioration at the Princess Alexandra Hospital. This includes aligning with statewide calling criteria and the introduction of a two-tiered emergency response. There will no longer be a single rapid response team at the Princess Alexandra Hospital. Instead, there will be a medical emergency team, or MET, who will respond to MET calls. There will also be a Code Blue team, who will respond to Code Blue calls. A MET call should be initiated when a patient's vital signs are calculated and give an early warning score of 8 or more. A MET call is also triggered by an E for emergency with a single parameter. A MET call should be triggered for any serious concern that is not triggered by the previously mentioned calling criteria. A Code Blue is initiated when a patient has a threatened airway or is in severe respiratory distress, for any patient with major hemorrhage, or for any patient in cardiorespiratory arrest. QADS adds a quantified oxygen component to the vital sign thresholds, which aligns with recent Australian Thoracic Society of Australia and New Zealand guidelines that recommend escalation is based on a patient's oxygen requirement rather than their oxygen saturation levels. Documentation of oxygen flow rate, or FiO2, is required as part of the QADS score. Documentation of neurological deterioration will now be completed using the AVPU scale to measure level of consciousness. The AVPU acronym stands for A, alert, V, verbal, P, pain, and U, unresponsive. A GCS should also be completed if a patient is unresponsive or disorientated. Other neurological observations, including pain, functional activity and sedation scores, must still be recorded at a frequency appropriate to the patient's clinical condition. For example, patients who are receiving opioids or other sedating medications. These values do not contribute to the QADS score, but are standalone parameters that are included in the medical emergency call criteria. So what does the QADS score mean? An individual score is calculated for each vital sign based on a clinical range. The individual vital sign scores are then added together to generate an overall QADS score and documented as an early warning score in the IEMR. If you have entered the patient's vital signs through interactive view or via a vital sign monitor, you will receive a discern notification message. These discern notifications support escalation of the patient's deterioration and provide timeframes for a response. An increase in observation frequency and response timeframe must be followed. For example, an early warning score of 1 to 3 will direct the clinician to review vital sign trends in the managing deterioration graph and to consider increasing frequency of observations with a minimum of 4th hourly, and to consider notifying the team leader. The response to deteriorating patients at the Princess Alexandra Hospital will now be graded depending on a patient's early warning score. Escalation processes prior to an emergency response mandate timely senior nursing, resident medical officer, or registrar review based on the extent of the physiological derangement. Discern notification alerts provide clinicians with observation monitoring plans and mandated timeframes for a response.
An early warning score of 4 to 5 requires the clinician to notify a resident medical officer to review the patient within 30 minutes and also notify the nursing team leader, while a score of 6 to 7 requires the clinician to notify the registrar for review in 30 minutes. If the medical review does not occur within the required time frame, the clinician is required to escalate to a more senior member of the team. For example, if the RMO cannot attend, the registrar will be contacted, and if the registrar review does not occur, it will be escalated to a MET call. With this in mind, it is important for medical staff to consider how they will facilitate the timely review when they are scrubbed in theatre or performing other critical clinical activities. Who can you direct to review the patient so that a MET call is not unnecessarily called?
When the early warning score is 8 or greater, or there is a single parameter in the emergency zone, a MET call criteria discern notification will appear in interactive view or on the vital sign monitor. This prompts the clinician to call 666 and state MET call, the patient's location, and the treating team.
In the situation that the patient has a threatened airway, severe respiratory distress, major hemorrhage, or cardiorespiratory arrest, then the clinician will call 666 and state code blue.
The Managing Deterioration page provides a graphical view of patients' vital sign trends. It also provides guidance on what course of action to take when a patient's vital signs fall outside of the recommended range. Yellow and red pop-up alerts will display in the Managing Deterioration page when results entered are in the clinical review range, yellow zone, or the critical range, red zone. With QADS, the alerts will direct the clinician to escalate as per the early warning score in interactive view and additional criteria, link above graph. Alter calling criteria must be authorised by a senior clinician. This refers to a senior medical officer or registrar and applies to the current encounter only. There are two types of alter calling criteria that may be recorded for a patient. The first is chronic alter calling criteria. This is valid for 30 days and should be reviewed on the Managing Deterioration page daily. Chronic alter calling criteria will automatically reset to standard calling criteria once the time frame expires. The second type is temporary or acute alter calling criteria. This is used for acute conditions requiring temporary alterations and is valid for 24 hours, at which time it will automatically reset to standard calling criteria.
Temporary modifications to altered calling criteria in acute illness can be associated with clinical risk. It is recommended to only alter single observations at any one time for short durations. For example, an isolated low or high blood pressure being altered for 4 hours. It is not recommended to apply simultaneous modification of multiple parameters, as this may in fact represent significant pathophysiology, and this altered score may lead to delay in escalation and review. For any temporary modification, it is important to clearly document the reason for alteration, the management plan for staff to follow, and a contact number should clarification be needed. There is a difference in how to modify the calling criteria within the IEMR for the Between the Flags and the multi-trigger tool. With Between the Flags, modification is required to alter the yellow and red ranges, which is then reflected on the Managing Deterioration page and the relevant alerts. When altering call criteria in the multi-track and trigger tool, medical staff must adjust values of the normal grey zone, which means the normal range contains a desired range for that parameter to score a 0. The normal grey zone can only be altered by changing the yellow zone. Changing the red has no effect on the early warning scores. Scores outside the new normal range will fire as per usual. The transition to QAD's multi-track and trigger tool aims to provide earlier and more accurate identification of patients at risk of deterioration. One of the benefits is that it allows early escalation for ward-based review by the treating team, which may prevent further deterioration needing a MET response. The key points for you as medical staff are: number 1, there will no longer be a single rapid response team at the Princess Alexandra Hospital. It will change to a 2-tiered response. There will be a medical emergency team, or MET, who will respond to MET calls, and there will also be a Code Blue team who will respond to Code Blue calls. Number 2, the early warning score will trigger escalation processes that mandate a timely ward-based review by senior nursing, resident medical officer, or registrar. This will correlate to the extent of the physiological derangement. A score of 4 to 5 will call for an RMO review in 30 minutes, and a score of 6 to 7 will require a registrar review. Please consider what your plan will be should clinical duties not allow you to respond in that time, for example, if you are scrubbed in theatre. Number 3, there are clinical situations where it will be clinically appropriate to alter the calling criteria. Consider the impact on the scoring and therefore what will trigger an escalation or an emergency response when temporary modifications are applied to acute illness. With any modification, clearly document the reason for the modification and a clear management plan for staff to follow. Number 4. Finally, this is a significant clinical change in how the staff at the Princess Alexandra Hospital will review and respond to clinical deterioration, particularly for staff who have not worked with QADs previously. Be patient during this time. Support the nursing staff by documenting management plans clearly. When called with an early warning score, it will help to discuss it in context of the full clinical picture.